perfect.
3, 2, 1. Okay. All right. So I have Dr. Frank here, and we were just chatting for a few minutes before we came on. I actually feel like I know him, but I just realized this morning that we've never actually formally spoken or met. It's all been through TikTok, and I feel like he's a kindred spirit, much younger than myself. But so I have him today, and as we posted, the discussion was going to be THC and recovery. But first, let me just, like I said, we just spoke. So let me introduce him. It's Dr. Frank. He has a pretty cool TikTok, and it's Dr. Frank here. Is that what it is?
That's correct. Yep. DocFrankhere. That's correct.
Doc Frank here.
Yeah.
And he also has a cool YouTube channel. What's the YouTube channel called?
Very confusing. That one is Addiction Mindset, which is the name of our recovery coaching company. So Addiction Mindset. Yep.
Yeah, I looked at a few videos, and it's all going to be posted on the thing here below. And I think, Doc Frank, are you family practice background, Doc Frank?
No. So this is going to shock a lot of people. And this is in my TikToks and stuff. So believe it or not, my background is actually in chiropractic care. And then I went on, and then I got certified as an addiction recovery coach.
Interesting.
And I opened up a company about maybe like a year and a half ago now. And so I'm really, my medicine background is in chiropractic care, but my recovery background is in recovery coaching. So that's the connection to all that.
I got it. And you seem to be really up on the tobacco products all across and THC. And I see a lot of stuff about your own smoking history. Do you also deal with a lot of, is there anything else you deal with?
It's predominantly tobacco, THC products. And then this one is also a curveball, especially when we're in like a recovery community, but energy drinks, ironically enough. I help a lot of people with that. And then we'll do some stuff when it comes to adult content or like pornography addiction as well. But those are the larger areas that I tend to operate in. And then we've been growing a lot as far as media content goes. So gaming, video game addictions are on a rapid rise right now. And that's a big thing that we're working with too as of lately.
So energy drinks is something I don't do enough because I deal with just really kind of, I guess, hardcore stuff. I mean, my clientele is everything from homeless heroin, polysubstance heroin guys to executives that fly in from different states to get off polypharmacy. But I'm very sensitive to and aware of energy drinks, gaming, and I watch this stuff. And tobacco products goes without saying. Now, today we're going to do the marijuana thing. And I was actually a little hesitant, guys, because both historically and the way this, and for a minute, I was like, wait a minute, is Doc Frank going to stand opposite on me on this, which I don't mind. But I was wondering if I'm going to lose a lot of viewers or disappoint people, but I got to really, really stay committed to my truths here and at least educate and inform people about what's going on. And it's nice that we have you on here so we can sort of go back, because this has really been a topic that I've struggled with, how to communicate with patients over the last 4 years. And as I said, there's a historical context to this, and it's funny, we fall into the same pit trap over and over and over again because of media, because of corporate capitalism and need for money, but it's sort of the same thing. So we can kick this off, and I think Nicole, because I am an idiot at technology, and Nicole's going to pop in here somehow and help me, because I already see David Collins waiting to come on and ask a question. So, God, I wish. Oh, there's Nicole right there. I wish you could help me out better. So, what are your thoughts on? We'll just start. Go
Sure.
straight into it. What are your thoughts on THC in recovery?
So when it comes to so you brought up a good point. You were real specific, THC in recovery. So
Yeah.
I always tell people when it comes to marijuana, are we talking about CBD? Are we talking about THC? And then what are we talking now about Delta 8? I saw some comments of people questioning about that. So I always tell people, like, because my opinion might be a little different depending on which cannabinoid it is that you're asking me about. But generally speaking, if we're talking about THC, I'm a large fan of harm reduction, so it certainly can fit into that category. Okay, but I always say I'd rather be hesitant on things, because if someone's goal, if they were suffering from, let's say, an opioid addiction or whatever it may be, and they've now transitioned into using THC, and if I sit down with this person at the end of the day and their quality of life has improved, they're doing all the things they want to do, and they're happy as could be with where they're at with their THC use, and it's safe, right? Like, let's say everything is deemed relatively safe from a health standpoint. I'm really happy for that person. I have nothing against it. But on the same note, as you guys may be aware of, I'm sure, just like there's a Narcotics Anonymous, there's a whole group, Marijuana Anonymous, MA. So there's people who I work with who suffer from marijuana addiction, especially now since we've seen the really high concentration cartridges, both black market and medical dispensary grade. And their addiction looks very, very similar to that of someone on a more hardcore substance or hardcore drug. The consequences of that addiction when it comes to relationships, finances, even to some extent health complications that we're starting to see that I really wasn't seeing prior in my years to doing this, we're now seeing. So in that case, I would say, well, wait a minute, maybe we need to pump the brakes here. Is this THC playing a positive role in your recovery? Or unfortunately, is this just becoming another negative that we're now going to have to navigate to? So I'm for it, but just very cautiously, and I'm all about the individual person. Some people might do really well with it. Some people, it might not be the right thing for them. So that's kind of my general view.
Okay. I'll give you my position on it. It was kind of an odd situation. So you have to kind of take my own personal historical narrative. I am not, and I don't label myself as anything, and hardly people would think of me as, as a physician being as such. But, somebody might call me extremely progressive, right? And I don't want to use those labels. And I'm from Berkeley, San Francisco area, all right?
Yep.
So when I was in college, you could be smoking a joint and Berkeley police would be walking by and they don't even look at you, right? And so at that time, I recall, there's guys that are on circuit court judges now that I knew in college that, were smoking dope, right? Okay. And at that time, I remember we used to be like, wow, this stuff is very, they used to say this stuff is very powerful. It certainly wasn't this way in the 60s. This is 100 times, 1,000 times more powerful. Okay, so, I've come through my whole life always, whatever. I don't care for pot. You want to smoke it, you don't want to smoke it. Once I started getting into this kind of space and line of work in medicine and dealing with pretty hardcore addicts, I started to notice something. I would go to the American Society of Addiction Medicine, and they would come up there and say the biggest nonsense that I thought was nonsense about marijuana. And I was like, God, these guys are all just like white-collar geeks. I hope they don't kick me out of my fellowship there. But what are they talking about? They're describing caffeine withdrawals. I go through that 3 times a week. Why are they making a big deal out of this? And I don't think, I think they were full of it. The data was nonsense and so forth. As time lapsed, let's say from about 2016 to 2019, 20, I started to notice something. And again, we have to space this out only with my substance abuse people. people in my detoxes and my IOPs and my sober living homes, I started to notice something. I'm like, wait a minute. There's no smoking pot in the homes, right? Or you just can't be THC positive because you're in recovery, right? I don't give a shit if it's legal or not. So is alcohol. You can't bring a fifth of whiskey and you get in a sober living home. And I noticed some of these guys that I had spent months to years getting off of heroin or methamphetamines and everything else, getting them off the street, they would not stop smoking pot at the risk of losing everything. And I remember this one gal, they brought her to me and I confronted her, and she was in a state of somewhat anger and panic and saying, I need this stuff. This helps me get up and go to work, this, that. And I sat there and the light bulb went off. I'm a little slow. And I'm like, sounds like an addiction to me, right? You're going to throw away your job, your sobriety, your housing, your all of your care. And then I was like, you know what? I'm going to put my foot down on this and really come down hard on it. Then from that, I started to notice something else. Again, we have to keep it. I'm talking about the clinical observation, which is really what's called anecdotal, was within the community of hardcore addicts.
Yeah.
So I'm talking about the guy, Joe, on the street. But in that group, I also started to notice the minute I started to get someone to quit marijuana, the recovery that would go like this and then stall. Well, and we're talking guys that were doing heroin and everything else. All of a sudden, there was a clarity with them and they shot up and went home. So that was the second thing that I was like, whoa, right? And I've never noticed anything but that within my community. Then I finally went to another talk in San Francisco. And this time there were some colleagues from UCSF, and I actually pulled her aside and I was like, are you shitting me? Is this for real? And I started to notice hardcore emergency department presentations from side effects of the marijuana people are smoking, most of them psychiatric and so forth. And then I started to notice legitimate admissions to programs for recovery because now this person was a serious physician's researcher. And I started looking at her data. Then I came back again. Remember, I'm slow. And I'm like, well, wait a minute. This stuff isn't even the crap we used to smoke in the 90s. This is a whole another ball game. And then from then, at that point, it's legalized. And it's out there. And today's attitude from parents, and this is going to be an intergenerational issue if we don't catch on to it, is very dangerous because people have less resistance to it since it's legal. And at the same time, cannabis use disorder, and again, I'm going to put it in general here, has doubled from like 2015 to 2018, from like 1% or 1.5 to almost 3. So my thoughts on it are for my group, no, you can't smoke pot, and no, I'm not being moralistic. I couldn't care less about Nancy Reagan frying your brain on drugs, right? Sure. That's all nonsense, but you just don't do well. The data's mounting up, and unfortunately, it's legalized. So just like heroin was at the turn of the last century, it was a cough suppressant. They used, people don't know this, but in the 1800s, after Merck, a pharmacist in 1803, I think, came up with morphine, and he isolated from the opium poppy, right? So he isolated morphine, which is the most active ingredient in that poppy. And then Merck picked it up and sold it as the treatment for opium addiction. But opium addiction is morphine addiction. And interestingly, that guy eventually became an addict and overdosed on it himself. And he was making it. So I see the same trend, and I just want to leave it at that. I don't know what you have to say about that.
I think that there's something very important that you said, and I'm going to reference one of your TikTok videos. And I think this will give my real opinion of it all as well. So you said people who struggle with addictions are often amazing people, empathetic people, caring people. And I would actually argue that people who struggle from addictions are extremely driven people. It takes a lot of work and a lot of effort and a lot of energy to put yourself through an addiction. Like it is a physical and mental workout every day to remain actively addicted to something. So when these individuals get sober and really get the help that they need, and myself being one of those in the past, I think they are capable of unbelievably incredible things in their life, whatever that may look like in relationships and finances and whatever that person is pursuing, because they have this, their brain is a little different, right? They can get addicted to whatever they want. And I think for a lot of people, that marijuana puts that at risk. I know with our clients, I don't have a firm yes or no on anything. It's a very loosely run program. How are you doing with that? You've decided you wanted to start smoking. And I can tell you, the people who stop everything do the best. The ones who put the weed down do the best. In our case, and again, I'm working with a different demographic, right? I'm not working necessarily with people coming off of heroin or this or whatever. But the ones who finally decide to put the pot down, it is amazing the trajectory.
Yeah, you saw that too, huh?
100%. And I saw that in my own journey through things too. The confusing part about that is, and this is to your point, because of media, because of this kind of lax behavior on it, I think there's, especially with a younger generation, you almost feel stupid to think, or at least I know I did, to think that I could do better without it, because I was being told by so many people, no, this should be helping you. This is good. This is okay. This is the accepted way. And I was just like, well, what if for me, this isn't working? So I think that's a really hard thing for a lot of people in recovery who feel that they've really been relying on marijuana to get them through it or to continue to carry them through it, to realize like, hey, maybe this isn't helping you as much as you're under the impression that it is helping you. So ultimately we have the same view, and I've seen the same trends, and we're going to see it. That trend is going to explode. That acceptance of it, that monetization of it, that it is exploding. And two, sadly, and you were talking about, you've seen it clinically in hospital settings and these addictions, what people are now consuming, especially with the overwhelming black market amount of products out there, people don't even know what they're consuming. I mean, they have no idea. We'd run drug tests on people, and they would pop up with things, and I'd have a young kid in my office crying, being like, Dr. Frank, I've never done that. And this is an optional drug test in our offices. I say, look, for safety reasons, I'd like to know what it is you're about to detox from, because if I got to get you into a medical center, I got to be aware of that, So, but sometimes they come back positive for things, and they'd be like, I've never touched an opioid. How are you telling me this? I'd say, hey, is there any chance that liquid you've been smoking was laced with something? Is there any chance? And the scarier thing is the withdrawals that they would go through were comparable to a much more hardcore substance. This wasn't just, so I hope that sums up my take on it. You kind of.
Yeah. And in fact, Volka and Coops, which are the kind of the fathers of the neurobiology of addiction at the NIH, data is coming out with the marijuana nowadays, and it fits perfectly in the model of dysregulation of the motivational circuits, right? And their model is something like, it starts off with binge intoxication, withdrawal negative affect, and preoccupation anticipation, and they correlate that with circuits in the brain. So it's good that you're actually also seeing it. I'm not crazy, but I'm starting to see evidence pile up. Doc, you want to I see David Collins here, and I do wish Nicole was with me from Real Talk Recovery, because she's a master at managing this stuff. But I want to get David on. He's been waiting a bit, and he might have a question for either one of us. Is that okay? Can
Yeah,
you see this stuff down here?
I
know.
don't see anything else. I don't see private chat
Okay.
comments.
So let me figure out if I can get because
Hold on. Yeah.
hooked me up with this super fancy thing to be able to.
Okay. No. Hold on. Okay, I see comments, Nicole. All right, what is it that I'm looking? Okay, I see the comments.
Yeah, you might not see it, but I'm about to add David to the stream.
Okay.
And Nicole's colleague, she showed me how to do this. So David, hang on. Hopefully I don't drop you. I wonder if you can even hear me. Oh, wow, I did it. I feel really technologically savvy. Hi, David.
Well done, Dr. B.
Thank you.
Thank you for having me on the show. I run a rehab here in Johannesburg in South Africa, and
That's right.
I bumped into you on TikTok as well. And I've been running my center since 2000, and our facility was a 12-step type complete abstinence Minnesota model approach.
Yeah.
And over the years, as the psychiatric industry's come in more and more, and marijuana's been made legal here, it's really interesting how the treatment industry's changed from going from complete abstinence to harm reduction. Oh, I can feel my nerves coming up. I can feel my voice starting to shake here as I'm talking to you guys. But I think technology is amazing. That's the first thing I want to say. And in breaking the stigma of addiction and getting people to start to talk about this stuff. So when it came to working with kids, to say, don't smoke dope, it's bad for you, it's a gateway drug, that whole narrative has changed because everything's been made, it's been decriminalized here now. And people are getting higher and higher on the hydroponic type dope, and we're getting more and more marijuana-induced psychosis coming into our clinic. So then it becomes difficult to treat because you've got a marijuana-induced psychosis, and that kid's got to go back into a culture, back into an environment that is very different from where it was, say, 20 years ago. Our treatment has always been influenced by an American approach, 12-step model, complete abstinence, and I think that is changing, or that needs to change more to become more aligned with what the World Health Organization and the United Nations are putting forward, that more and more people are being harmed by the war on drugs. That's actually got nothing to do with the users. So the stigmatization of the users just pushes things underground and fuels the criminal world. And more families and people that are impacted by this are being harmed by it. So when we have platforms like this, where people can start to talk and to share their opinion, it breaks it helps to break down the stigma and to bring recovery out of guilt and shame and into the light. Because I think addiction is the one illness that everyone has an opinion on. If we were talking diabetes or something, you'd listen to your doctor, and your doctor would say this, this, and this, and everyone would listen. With something like addiction, as soon as you mention, oh, so-and-so's got an addiction problem, every Tom, Dick, and Harry's got an opinion, and it leaves everyone within that family system or environment confused. So there's a lack of clarity because Uncle Bob had a drinking problem and Auntie May used to take pills, and, young Johnny's smoking dope there, and, they need to go and see this priest or that rabbi, and everyone in the community has an opinion, which just adds to the problem. So what I'm enjoying is the clarity that are we ever going to meet Jimmy, by the way?
Yeah, we just put up a video yesterday. He's up.
Oh, okay.
Yeah, go on there. He's on there. Yeah, he's on there. You could see him. David, you hit so many nails on the head, whether it's the World Health Organization or my frustration with everybody giving me, again, everyone has a right to their opinion, but I would often think, wow, when I practice, emergency medicine, critical care, trauma, all that stuff, people wouldn't give me their opinion as I was ripping their chest open and tell me, the way, which rib I should go under, which blade I should use. This is a very odd field, but you nailed it. Basically, what I follow myself is the World Health Organization model, and that's it, and the harm reduction model, and that's where I get my data mainly from. It's interesting you said we follow the American model. Even today, and this has been my goal, both to you and Doc Frank, my goal is just to start making a dent and a paradigm shift all across the board, to treating physicians, to the families, to the addict, right? Because your disease is certainly, to a certain degree, a function of the social milieu that you're coming out of. If you are a Native Alaskan and you move, or if you're a Native American and all of a sudden you move somewhere else, now you got cholesterol, diabetes, it's the same thing. And with this disease, if I can change society, if I can change the individual person's perception of it and turn it more in line with both a clinical model, but with that clinical model comes compassion, empathy, professionalism, and giving a shit about the person. So you nailed a lot of things that we try and do here, and I appreciate that, David. And yes, Jimmy is online. I don't know, Doc Frank, you have any thoughts on that?
No, it was very well said. No, I agreed with. No, that was very, very well said. It's neat too here in South Africa. That's cool.
One last thought I'll leave you with. The way we practice addiction medicine up to this point in the U.S. has been no better, at least in the private facilities, than snake oil salesmen at the turn of the century. We are at least 100 years behind. And in fact, 100 years ago, doctors in the U.S. were way ahead of doctors that we've come to, because they knew that what you got to do is harm reduction approach. They knew addiction is a disease. I mean, you could go back and read the literature from the turn of the century. They were saying that this should be approached as a disease, and these are human beings. It's very fascinating if you do that. But David, thank you so much. Thank you for following us. Go check out Jimmy. I think the video came out yesterday, so I hope you enjoy it. And thanks again.
Thanks for having me, guys.
Okay, bye-bye.
Nice meeting you, David. Bye now.
Bye. How do I get off this thing? Do you kick me out? Do you reject me? Do you kick me out? Do you hurt my childhood wound?
There should be a little button that says "Leave Studio."
Yeah.
Okay.
Remote. Okay.
Okay. Bye, guys.
There you are.
Okay. Should we go to Maureen? There's one more. Should we do that?
Sure, of course. Whatever you have. Yeah, of
We'll
course.
be open to how we do this. You got something you want to talk about? Please go in. Let's bring in Maureen.
Bring someone in. Yeah.
Oh, it says add to stream. Maureen, you got to bear with me. Like I said, I'm an idiot.
Well,
Maureen.
I'm not quite sure how to. Oh, there I am. I think I'm on there.
Hi.
Hello, Maureen.
Hi. So, you received my message, my chat?
Was it on TikTok?
I know, right here.
Oh.
Chat. Oh, I guess private chat. I thought it was comment, but it's
Yeah, you're in the chat. I see it there.
Okay, so it's for Doc. Okay.
So I see it here. Maureen, do you mind if I kind of explain what it says, or do you want me to keep that private?
No, you can go ahead.
Okay, you're okay with me just so Dr. B is aware here. So I'm gonna just explain what's going on here. Okay. So basically, you're just saying at this point you're struggling. You've overcome some other poly addictions, and you're tapering down from some things. And one of the things that you're struggling with is the marijuana addiction, using it sporadically, and you want off of it. Is that correct? Oh, I can't hear you. I think your microphone's muted for some reason.
Yeah, it's muted, Maureen.
You muted it.
You just got, yeah, there you go. Oh, you had it. There you
No. You're close. You're close. Almost there.
Okay.
I'm sorry, I keep hitting the button.
You're there.
That's
You're
okay.
there.
I'm an amputee and I've got 1.5 thumbs, and so I say I'm all thumbs.
That's all right. You're there. So Maureen, it says that you're struggling with some MA addiction. You've been doing good with tackling some other addictions, and you're using it sporadically, but you want off of it. Is that correct?
That's correct.
And Maureen, do you mind if I ask you why? Why do you want off of the MA? Why do you want to be done with MA, abbreviation for marijuana? Why?
No, it's not an abbreviation for marijuana. That's methamphetamine.
Oh, I thought. Oh, I'm used to marijuana. Okay, I'm used to it. So never mind. This one's for Dr. B. So Dr. B, you got to take this question. So
Okay.
it says currently tapering off methadone for 240 years and down or 240 mgs to 16 mgs. I'm struggling with methamphetamine addiction, using sporadically, want off.
Correct.
And the question is, you want off?
Yes.
Okay.
Yeah. Yes. But I think what happens is the depression and low energy is my big struggle. And so that's when I end up seeking that, because it corrects that for a little bit.
Yeah. Maureen, let me ask you, what state are you in?
I'm in Canada. I'm in Ontario.
Oh, so this is a very complex question. This is my bread and butter. This is what I do. So number one, please understand, I can't give medical advice to an individual on here, but I can give you some general things. Have you cut down on the methamphetamines?
Oh, considerably, yes.
Are you smoking
Yes.
it?
Yes.
Uh-huh. And how much methadone are you on?
16 milligrams.
Oh, that's not bad. And you started at 240?
Years ago, I was at 240, but most recently I was at 70 milligrams about 4 months ago and started to taper.
Holy shit, you're kicking ass. Wow. That's
I'm an amputee as well, a bilateral amputee.
Bilateral what? Upper extremity, lower extremity?
Well, 8.5 fingers and both feet and ankles.
Okay.
I had meningitis 8 years ago.
Oh, okay. All right. Gonococcal, or do you know what kind of meningitis?
Neisseria.
Yeah,
Neisseria.
Neisseria meningitis. Okay. Not gonococcal, Neisseria meningitis.
And
Yeah, okay.
and I went DIC.
Okay.
I went DIC, and that's why I lost my limbs.
Yeah, yeah. I mean, I've seen a lot of those cases in my other life. Listen, just briefly, just so you're aware. So it's kind of impressive you cut down on the meth, and a lot of people end up increasing it because it's almost like a catch-22. You got 3 neurotransmitters in your brain that get depleted from the methamphetamine use. And then, there's the acute crash and the long crash. Here's the thing. So I don't know, I know it's kind of universal healthcare up there, but you will have to get through that crash phase, because you're sort of in this cycle. You're doing it to stay awake and not depressed, but you're going to have to go to the depression and mood swings to get off. And then when you're doing it, usually it goes up. I'm kind of blown away that you've cut down.
I get through the acute phase, and that I can handle that. It's the chronic.
Yeah.
It's like a month later,
How long?
a month later, or 6 weeks later.
And
I
see again, I don't. There's so much I would have to get. You know, are you on any psychotropics? Are you?
I'm on gabapentin and oxazepam, which what used to be 50 milligrams. It's about 15 milligrams a day now, and not every day.
Yeah. How much GABA are you on?
I'm prescribed 1,600 milligrams 3 times a day. However, I take 1,200 milligrams twice a day.
Is that for neuropathy?
It is.
That's a big dose.
It is.
Yeah. So again, I really want to be cautious I want to give general advice here. I would really enjoy you as a patient, actually, because I'm confident in what I do, but I think I can give you better quality of life in about 8 to 12 months. But what you should know is that are you able to exercise, get your endorphins going?
Yes. Well, currently I have an infection. I have an infected bursa. Well, actually, it's not infected anymore, but it's still open and draining. And I'm dealing with my surgeon and my family doctor. We're trying to make a decision as to whether they're going to do a debridement or a revision.
Nice. I'm glad you're up on what's going on with you. So on the meth, the only thing I can really say, because there's a whole bunch of stuff here that one would need to look at closely, change things around, get things going. Whatever you do, don't go back up on the dose.
Right.
That's really critical. Number two, you gotta allow those transmitters to sort of repopulate, and that sort of long-term withdrawal, protracted withdrawal thing can potentially go for months. Now, you're not my patient, so I can't see you. And really,
it does go for months.
Yeah. So
I mean, I got off it for 9 months a couple of years ago,
and
but yet here I am.
Yeah, and that's when you need to potentially look at. So it's let me break it down in the most general way. When that goes on in that way for months and months and months, it's 2 issues. One itself is protracted withdrawal just straight from the methamphetamine. Oftentimes, it's the very reason the methamphetamine was used to replace some other issue. With some people, it might be attention spectrum issues, right? All kinds of emotional stuff. So whatever you do, you got to figure out which one it is and seek some sort of treatment, whether it's a xenobiotic, a drug, right? And I don't mean a hardcore drug, maybe it's on for sleep. Maybe it's backing off the gabapentin. Maybe it's an antidepressant. Or addressing the original issue that caused the methamphetamine use, misuse, and abuse, which can be treatment for trauma as a child, right? Emotional abuse, sexual abuse. It might be your attention deficit. It might be needing more endorphins for exercise. Usually, it's
my addiction started very young. It started at about 11, and it started with marijuana and alcohol, and then progressed to cocaine, heroin.
So those are the 2
gamut.
I have to tell you is to so don't go back up, stick it out, and then get help, whether it's mental help for trauma, emotional stuff, whatever, and figure out how the 2 are linked. But once you get off, don't go back. I got a guy that I'm treating right now exactly in the same situation. Maureen, thank you so much. It's very difficult on this platform for me to get ethical advice to you because my patients, B, I need so much more information. So I try to do the best I can. Doc Frank, do you have any thoughts for Maureen?
No, Maureen, I think you're already in a fantastic direction, and I think you're gonna continue to excel. You just got to put you're this close. You just got to put those last pieces together. You got to just go.
That last step that I have a hard time with. It gets me.
You're so close. You're right there. Just like Dr. B. Just go get that little extra push, wherever that comes from, whatever you have access to. And I think you're going to do great. Can I ask you something real quick? Why is it that you want to stop? Why is it that might sound like a wild question, but
well, I'm 51 years old. I have 2 children, a 33 and a 14-year-old. I'm an amputee. I'm a single mom. I have family, I mean, all kinds of health issues.
Yeah.
And it's just, I want to change my life. I need a change.
Of
I've
course.
been doing this for 35 years, struggling with these addictions, and it's time. I want it to stop.
It's time. It's run its
Yeah.
course. It's time. That's awesome.
Yeah.
Maureen, I can tell you too, from that brief history, you sound like you've been through quite a few different things in your life between the amputee and the single mom and the kids. So I could say
Yeah.
with confidence from a motivational coaching side of things that I do, you've probably been through some challenging things before. And I wouldn't doubt if you get that last little piece of this, you're going to be able to get through this as well too. I wouldn't doubt that for 1 second.
Well, thank you. Thank you. I appreciate that.
I was blown away by how rapidly you came down. So
Look at that. Look at that. The man himself. See?
Yeah, I was actually kind of like, damn, she'd be fun to have because we're going to get somewhere pretty quick. Okay, Maureen, good luck. Stay strong. And we're here if you need us. Okay.
Okay. Yeah. Thank you both very much.
Bye-bye.
Bye.
Okay. Oh, I see someone else in the queue, and it's Nadim, and I know Nadim. He's from the Netherlands. Before I bring him on, I'll tell you, Doc Frank, Nadim, I know him from, all of this stuff. But what blew me away about this young man was he's from the Netherlands, and he's originally from the Middle East, but he speaks better English than I do. And I was like, I got to talk to this guy. His syntax and grammar is exquisite. So let's bring in.
Now, Dr. B, can you see this? These are great questions, and these are exciting. I love the questions he's asking. Can you see in your comments, if you flip over to private chat, you're going to see his question there.
Oh, thanks.
I can read it, but that was where Maureen's was too.
So I push private.
Private chat.
I just sent Nicole the text saying help. I have no idea. I can't even keep up. So
yeah.
I'll pull. Okay. Oh, there's Nadim. Oh,
so
there's Nadim.
Okay. He has 2 questions there, and I think you can see them. So he's asking, and this is for everyone who can't see it, is there a clinical difference between a slip and a relapse? That's question number 1.
Yeah.
Question number 2, from a patient's perspective, do you think that labeling is more helpful as a mean of a reality check or harmful by creating obstacles, i.e. once an addict, always an addict? So 2 questions.
Okay, I'll bring Nadim on, and it's funny he asked that. Should I answer that? In fact, I posted a TikTok on this, and it created some questions, and I was like, I got to address this, and this might be a perfect time. Let me, hi, Nadim, how are you?
Hello, hi, how are you, Dr. Hello, Dr. Frank.
Hello, how are you? Nice to meet you.
Nice to meet you too.
Of course.
Nadim, it's funny you asked this. Dr. Frank, may I go ahead and give a...
Go, please. Yeah.
Yeah. So you asked every question relevant to this issue, and let me. What I posted on TikTok was an episode of use is not a relapse. Why is that change in language and understanding the conceptual framework that occurs in important? Here's why it's important. Because you got Joe Blow out there, and he's gone through hell. Now he's counting his days. No knock against 12-step, but he's a 12-step guy, so counting days is important. He's like 90 days, 100 days, 150 days. He's going to meetings. He got a room he's renting. He got a job. Bam, he uses, okay? The way that we have it set up at this time, and we call that a relapse, right? The way it's been is that, what does that do? It works negatively on multiple components. Number 1, on the patient, on the client, it creates shame, right? Because of the expectations and the demands of sometimes the very Nazi approach to a militant approach, to staying clean. Oh, I failed, okay? What is the number 1 of relapse is stress, shame, all that stuff. Now, what does that do? Well, let me tell you that it's much easier to keep doing what you're doing at that moment than go back and face the music. Another level it works negatively at is the way we're set up, okay? The way we're set up there's so much money flowing back and forth traditionally in detox, residential, IOP, and I'm in this world where any asshole, oh, you got to go into detox, and it's like, really? I got to give everything up I have and go on detox so you get paid $3,000 a day. All these models are set up, and I've never. I look at the intensity of care needed and severity of disease. I couldn't care less what level you're at, right? It could fall into it, or it could not. And so all of these things have had a very negative effect by calling it relapse. And I was advocating this for years. And finally, I think they changed it. And so here's what it is. All those clean days you've had, months you've had, your brain is plastic. By definition, that's a technical term, neuroplasticity. You've built new neurocircuitry to give you tools to cope with stress. Every day you've had clean is a day you add under your belt to get a tool to deal with stress. And the way this should work, let's say me or Doc Frank or you, we don't know we're diabetic and we're just sucking down sugar. And then the next thing you know, you're pissing away and you're super thirsty and you're tired. Bam, next thing you know, you're in the ICU with DKA with a tube down your throat, trying to become a blow off acid. Okay, now you get out, they tell you you're diabetic. Okay, oh, okay, great. These are the medications. Here's the education. Here's your diet. Here's your exercise plan. Over time, if you did it right, you can have your diabetes under control. So on that one day where you go to your sister's wedding and you're like, I gotta have that cake, and the sugar spikes up, now you have the tools to deal with the sugar without having to go to the ICU, right?
Okay. Yeah.
So whereas with every episode of use, we're calling it ICU admission, right? Now, let me go on the other side of this. I hope this is answering your question. The other side of this is when Nadim comes in, when Joe comes in, when Melissa comes in, and you're like, hey, don't worry about it. Relapses relapses, if you want to, are the norm, not the exception. Now you're telling that guy, oh shit, you got this for life. And number one, you're kind of it's self-defeating. And number two, you're actually creating an okay signal. Don't worry about it. Go ahead and use. Now, this is where you as the clinician have to have a good, deep understanding. When you tell them that and you want to set them up, you have to have a nice long preamble and say, I'm not here to judge you. This is a bumpy road. We're going to go the way we go. You give them an explanation of the chronic disease model, but you also explain to them, hey, Joe, let me make sure you understand something. I'm not telling you once an alcoholic, you're an alcoholic for life. I'm telling you, you have a disease and it could pop up here and there. We are aiming for long-term remission. You are in control to a great extent. If something happens, it's okay. Let's get a hold of it. But do not under any circumstance think I'm telling you go and do. So it's not just you gotta.
That's exactly why I said in the question it might be contradictory. My questions might be contradictory because that's very important, because I know that it's not like someone can tell me like, yeah, go ahead and yeah, of course, you have it under control. I don't think that's how it works. But just putting the barrier so high all the time, I'm just trying to figure out how is that impacting me. And I'm so afraid of failure and having built that much sober time. So basically, like from crystal meth and GHB. So basically, even like having a beer freaks me out. And I think sure.
Can I just tell Doc Frank a little? Am I allowed to give a little history?
Of course.
I'll give it. Nadim lives in the Netherlands. He's a really bright, intelligent young man, early 30s. Has had a history mainly with methamphetamine and GHB. And he's had, I think, a year or two clean time, and super smart guy, works, has a really cool job and very insightful and thoughtful. So just a little history for you, Doc Frank. And sorry.
No, that's okay.
Go ahead, gentlemen.
I think Dr. B covered that really well, and I share the same opinion with him on it. When people come to our offices and when they do have a relapse or an incident of use, however you want to put it, we do our best to not dwell on it, and we just try and look forward as quickly as possible with that person. But we're all about, so my first question is usually what happened, and then they'll explain to me whatever it was that occurred, and then we'll immediately try to move to how, if those situations arrive again in the future, how could we prevent that instance from occurring again? What could we have a plan of action? Could we have a plan B if you find yourself in that situation? Maybe it's calling a sponsor, maybe it's just changing the environment, whatever it is. It's usually nothing too complicated. And then our expectation to people is, at least in our programs, we say, listen, just like Dr. B said, like, this is a disease, but the neat thing is you can have a plan for situations that come up in the future, and it's on you whether or not you're going to use that plan that we talked about. You have that responsibility, and that's kind of how we approach it. But I couldn't agree more that yeah, I think that it's a tough one. That's a tough question, but we always just try and move forward quickly from it in our program. Acknowledge what happened. Let's come up with a plan. It's your responsibility now to make sure that that doesn't happen again. And then hopefully it doesn't. And if it does, we just work with them on it. I think I couldn't agree more too about the guilt and the shame. The last thing you want to do is make someone feel worse about themselves. That's the last thing you want to do. Why would you want to do that to anyone, especially when you're in recovery? That's the exact opposite of what we're trying to do. So yeah, very cool.
Great.
Cool.
Thanks a lot. Thanks a lot.
Keep in touch with us. Check out Nicole.
Course.
That's a good way to keep in touch with all of our program. And Doc's channel is pretty neat too. He's got the YouTube, and he's a good guy. He's really I like him a lot.
Thank you. It's a different level of entertainment. I'm working with, I'm in my 30s. I take it you're about the same age. I'm working with people mostly in the demographic of like 16 to maybe 20. So it's a little different, but I hope you enjoy the content if you find it. So
I will take a look.
Talk to you soon, buddy.
Thanks a lot. Thank you. Bye. Thanks for the time. Ciao.
Doc, I'm worried that I'm not addressing everyone's need, because there's a TikTok going here and stuff over here, and I'm sure there's all kinds of questions, and I don't know what to do. And I wish Nicole was here, but she's on there somewhere doing something. But
I'm here. People are just talking. They're talking. There's a lot of conversation about judgment in the comments and people being judgmental, whether it's physicians being judgmental, whether it's family members being judgmental. There's a lot of conversation going on about that. So do you have any commentary as far as that goes when it comes to judgment, as far as Suboxone use goes? And actually, I know too, you get the same thing within the recovery community, right? Half the people are saying you're not sober if you're on Suboxone. The other half are saying, yes, you are, you're doing great, or whatever that is. So what's your opinion on judgment when it comes to that, especially with frontline workers? There's a lot of conversation about that.
Yeah. I mean, it's one of the foundations of what I try to do in all of our practices. We call it the company, the things that I run, because none of us, we work extremely hard to be non-judgmental, but empowering, but not enabling. In fact, that's the magic of what we do. But through all of this stuff that we're doing, my goal here is to get rid of judgment in this way. In fact, it's nice to see that. I think I got a letter from, and I hope she's watching. We got a handwritten letter from someone in New Mexico. It was so cool. I opened it, beautifully written, handwritten letter, and I have it posted in my private office wall. And she's like, I found you, I think, on TikTok. I am not an addict, but because of what you've educated me something to the effect that I've completely changed my views on addiction. And I think she was reaching out to family members that are addicts. So the judgment has to go. And if one wants to understand how did that come about, I can assure you it's not biblical. Just find the historical roots of how these judgments came about. I alluded to some of it when you follow the Harrison Drug Act of 1914 and how things became illegal and so forth. This is just nonsense. You know, we live in one period and the addict has a disease and we approach him with compassion. The next period, he is the scourge of society and, you know, and using medications is also being an addict. And so one of the keys here is I have always believed, in fact, my mother instilled this in me, is education opens the mind and gets rid of judgment, racism, and it's the great equalizer in the world. And I have lived by that my whole life. Understanding, formal understanding of things, not everyone's opinions, you know, not saying everyone could say what a formal understanding of things takes away mystery, takes away voodoo, and it takes away judgment and witch burning.
That's true. So you're saying through education, whether it be with other physicians or the general public, when it comes to addiction, that's how we can start to tackle judgment.
I do.
That's absolutely correct. And a big thing too that I would, I couldn't agree more, obviously, but that I would say to the people asking about judgment, and I think this is a big thing that I run into when I'm working with people. You mentioned earlier talk therapy and going through therapy and stuff. A big issue that we run into and a big thing that drug addiction damages in a person is confidence. So your confidence is kind of beaten down and it's kind of demoralized. And I think when you don't have that shield of confidence up, not cockiness, not arrogance, just a shield of confidence, it's very, very easy to let other individuals' judgment really damage you. It can be very, very, very damaging. So one of the things that I would recommend you guys to do is find someone that you're able to work with who can help reinstill, and I don't know if it's actually confidence is the issue because, and Dr. B, you know, this is billions of people, millions of people, however many people in the world. We'll do as much as we can, 100,000 people at a time on TikTok to change their views on judgment. But you're always going to have that one prick. You're always going to have that asshole that you come across who's going to judge. And I think the stronger you guys can get in the chat and the stronger we can get as a community, the more we're going to be able to deflect that judgment when it does come our way. So I think anything you can do for yourselves in your sobriety journey, in your recovery journey, that's going to rebuild your confidence, whether that's focusing in on maybe something you're really good at, right? Maybe you're really good at a hobby or really good at something. You can just go ding those things that you're confident in. I think that's going to really help you deflect that judgment when you do come across it. And you combine that, I think, with community education, and boom, you guys should be bulletproof to judgment when it comes your way. So, yeah.
Go ahead.
That was all. That was it.
I love what you said there because it actually alludes to another TikTok, and I've always felt funny about TikTok. I got 30 seconds to talk about something that I would usually spend 5 to 6 hours on with something. But when you talk about building self-confidence, you just nailed the issue. And you know, I actually believe, you know, I've treated over 40,000 patients between this and my other medical teaching career. Yeah. And so I love patients, but I am very more interested in some ways in the social and psychological paradigms of substance abuse, where it comes from. And I've always argued, and in fact, the literature, good social theory literature, historically and presently, backs me up, validates what I'm saying. You said self-confidence. Most of us in today's society lack a strong sense of self. Mm-hmm. And on TikTok, I was telling people, don't find meaning, don't give your children meaning from the outside world. Who gives a shit about the brand clothes or what the other? have them find their meaning in themselves. And if you do that, I fully believe, and I think the literature is, can really show this, you build a strong sense of self, the psychological self, right? The ego. And if you do that, now the issue of confidence is almost, goes hand in hand. And you nailed it within this community. There may have already been an issue, and most people, I really hate that most clinicians just forget about this, but most of these folks have severe anxiety and panic issues that need to be addressed. Now you've stripped a drug off of them, and a lot of that has to do with self-confidence. They get agoraphobia, all kinds of stuff, and you nailed it. And so really this begs the question, Doc, and I'm going to present it to you. You said what they need to do, and that's exactly what they need. Here's the problem. Most folks don't have the resources, and most people out there doing this stuff don't really understand the importance or have the qualifications or the insight into what these folks need. Now, it's really cheap to create this as a system in the country where everyone gets in it, but it's so difficult. But you nailed what's needed in different words, but I could, and that's how you prevent long-term relapse.
That is could not agree. That's it. That's when people ask, how do I stop relapsing? Well, that is how. That is ultimately how. But you're right. The access to that is a whole different story, and then the people then carrying that out is a different story. That is a monster challenge that hopefully grows. I mean, I think you're David, who was on earlier, technology. Hopefully with technology, we can start to close in on this gap.
Yeah, absolutely. You're right.
Like we're doing right now. I mean, who's ever here, we're already starting that. And your TikTok, my TikToks, tons of people in the recovery community on there. That's the best. That's the best thing. Yeah.
Absolutely. I'm going to bring on Jose, I think.
Okay.
Ready? Okay. Here goes Jose.
Yeah, I had a question.
Hi, Jose.
I had a question.
Yeah.
All right. So, I just recently got off of fentanyl due to an overdose, sadly, and I was advised to take Suboxone. So they started me on 8 milligrams, and this was, I believe, 4 days after the overdose. So it was out of my system. They used the Cal score. They did all that, and they landed on 8 milligrams of Suboxone. That was the treatment plan. So they gave me that, and I started feeling highly euphoric. And I told this to the nurse, and I said, is this normal? And then they brought up something about maybe it's because it's a low dose. So when it metabolizes, it turns into a full agonist or antagonist. I'm not too sure how that works. So I had a question about why is it causing euphoria?
Should I go ahead, Dr.?
Yeah, this is not my. Yep, you go for it. Not my.
Let me ask you this: you overdosed. When you said overdose, was there intubation? Were you down out for 4 days, or you overdosed and then they waited 4 days to give you the Suboxone?
Correct. So the second thing you said, I was brought into the emergency room and kept there for 4 days at pediatric rehabilitation. Okay. So I was being basically monitored, checking my blood pressure, temperatures, and stuff like that. So yeah, just that overdose, and then I stayed there for 4 days, but I was not out.
Okay. And on the 4th day, the first thing you got was an 8 milligram strip of Suboxone?
Yes, it was a 8 milligram strip sublingual.
Yeah. So I would know. What state do you live in?
I'm in California.
Oh, where?
I'm in San Jose, California.
Ah, San Jose. What street?
The street I'm in Las Vegas right now.
Oh, what street do you live on in San Jose?
I live on Chesterton Circle.
Ah, I don't know that one, but I do know
it's near Berryessa. It's in Berryessa area.
Yeah, I used to live in Sunnyvale when I was a little kid. So
that's not too far. Yeah, I'm familiar.
Up in Palo Alto. Listen, and how old are you?
I'm 18. That's why I'm kind of concerned.
And how long have you been on the subs now?
This is the 3rd day.
Oh,
after that, so yeah, it's only been.
And how much are you on a day?
I only take so they give me a 4 milligram and cut, so 2 milligrams 2 times. So I take that 2 times a day, so 4 milligram total.
Yeah. So I don't think you're getting any euphoria now, are you? I'll tell you what happened.
No, I'm saying not now, but it
So
caused.
I'll tell you what happened. Yeah. So you basically describe. So on the 4th day, they gave you 8 milligrams because they were just worried about precipitated withdrawals, and they held it for 4 days, which you don't need to hold for 4 days. But on that 4th day, I wouldn't give you 8 milligrams because you're going to get a rush, right? I would have given you 2 to 4 milligrams. A few more hours later, giving you 2 to 4 milligrams. It wasn't because of any breakdown product. It is an opiate nonetheless, even though it has this property of being an agonist antagonist and that euphoria. Look, if you gave me 4 milligrams of subs right now, I'd get a rush, right? But if you gave me 25 milligrams of blood pressure hydrochlorothiazide right now, I might get dizzy, right? Because my body has to adjust to it, and it drops the blood pressure. What they should have done is giving you 2 to 4 milligrams every few hours and brought it up slowly. And then whatever the adjustment dose is, the real way to do this is there's only one marker you're looking for when you put someone on maintenance medication, to the main markers, the primary end goals. Are there any cravings? Are there any withdrawals?
That's the thing. There wasn't any cravings or withdrawal, and it was due to that whole experience where I even told the doctor this is causing euphoria. So I'm not sure if maybe that's why they decided to say, you know what, maybe 2 milligrams twice a day. I'm not sure how that plays a role, but
yeah,
I was just very intrigued when the doctor told me about this metabolized drug that I guess the buprenorphine metabolizes into. That was their explanation.
Well, it is that. No. So it is that because the metabolite is active metabolite. But if they give you a much smaller dose, the metabolite is much smaller, and you shouldn't get that rush, right?
Exactly. No, yeah, exactly.
Yeah. You shouldn't have gotten 8 milligrams. You should have gotten 4. And I don't know if you're underdosed now or whatever. But in the long run, even though you weren't having cravings and withdrawals on that day, the right thing to do, depending on how long you've been using, is to start on MAT, especially when someone, I don't know if it was your first time or whatever. Again, I'm not going to try and make a medical evaluation. It's not right for me to do that. But to answer your question, the dose initially given was too high for somebody, even 1 day out, right? It's too high. I usually give that dose when someone is, because my cows, I do it in a few hours. I don't need 3 days. Yeah. You come in, and if you feel like hanging out with me, I'm going to get you on. Nobody goes through 2, 3, 4 days of withdrawals with me. Cows is a validated scale that I just had a guy this morning. My PA's got him on. He did stop using yesterday afternoon, and comes in this morning, I think yesterday afternoon, and started. He's in fact being inducted right now with 4 milligrams, and then once I'm done, so you don't have to wait 4 days. Does that help, Jose?
Yeah, I do appreciate the response, and I will be in contact with you. I appreciate you. And one more thing, I just wanted to say, what you do with the Cal score, I think that's really genuine of you. As my experience, it's just a couple questions, and then we have a score. You know what I'm saying? So I do appreciate you. You're a really good doctor.
Thank you, Jose. Doc Frank, do you have any feedback for Jose? He's actually right in your age group.
Yeah, you are. Are you, no, man, all I could say is congratulations. I get in touch with Dr. B and just go forward on this path to recovery that you're on, man. I can say that. I'm listening to you guys talk, and you guys are talking about things. And I got a medical background, and I'm saying, like, damn, this guy is smart, because you guys are talking about metabolites and other things back and forth real quick. And I'm following, but I'm like 18 years old. You're following. What's your background in, Jose? Are you in school? Are you working?
Yeah. So that's one thing I'm very interested in: pharmacology, psychology. I'm very interested.
I can tell by listening to you. You're a very, very, very sharp individual. That's all I have to say by listening to you talk.
And I really appreciate that feedback.
Yeah,
and Dr. B, likewise as well. I do appreciate your feedback. Everything that you helped me with today. Yeah. You helped me
Yeah,
out with a couple questions.
Dr. Frank, you're right. Yeah, I didn't even think about that because I'm really.
I was listening to this
on-
conversation. I was like, I'm getting left out here. I don't know. I'm missing steps. And then I was like, oh, he's keeping up just fine with this. I'm kidding. But I'm not.
Yeah, Jose, give us a call. Give Nicole a call. See if we can do anything for you. Okay, kid?
Most definitely, yeah. All right.
Good job, man. Keep it up.
Thank you, guys.
Bye, Jose.
That was a smart person. Most people 18 would have not kept up with the conversation at that level.
That went completely over my head. Usually I catch things like that, but I'm so involved in trying to listen.
Yeah, you were focused. You guys were focused. That was cool. That was good. Super, that was cool. That was a really nice. He was a nice kid.
Yeah, nice kid. Great pickup. Let's continue. I don't see anybody in the queue. Where were we? We were talking about something interesting. By the way, how much time you got?
I am on until about 1:50, 1:55. So we got a few more minutes here.
Oh, a few minutes. Great.
Yeah.
I'm sure I got like 8 missed things, and people are going nuts on me. But I'm wondering. Hey, here's TikTok. Hey guys, here's Doc Frank. If you don't,
it's really funny.
You guys should be on the YouTube, and Doc Frank here is also on TikTok. This is.
I'm just.
Doc, you ever going to come out to California? We'll see if any questions pop up here. We can, but if you ever come out to California, come check us out. You ever come out here?
Oh, definitely. No, I have not, but that's in our eventual plans. That's in me and the wife's eventual plans here. So that's an area we'd like to go visit, and maybe we could do some collaboration. She's actually she's a physician assistant in gynecology care. So
up there?
No, yep, in New York here. Yep.
Oh, awesome! I just actually brought on. I'm real possessive of my patients, and I finally brought on a clinician that I really, really like. Her name is Alexis. She's a physician assistant, and she kicks ass. And I love it when patients call and they're like, "Hey, is Alexis there?" I'm like, "Oh, awesome!" And they're leaving. I can go attend to someone else. But yeah, that's cool. We should do more of these. I think we in general gave our thoughts on THC in recovery. There's a lot more to cover in THC, which you have a lot of insight out on because we didn't discuss all of the cannabis.
That's okay. This was our first one together. We started there and then we just jumped into other stuff. That's okay. But something I do want to say that people are talking about, and I think there's two sides to this. And I know you run a non-for-profit, if I'm correct.
One of them, yeah.
One of your companies are a non-for-profit. And people are talking about the cost of care and the cost of recovery and how can I afford it, and a doctor's appointment shouldn't cost this much money and all that stuff. And I want to say something on that. So I think there are tons of resources out there. You have free resources, you have very, very expensive resources. You could pay cash $90,000 a month and go to some, top of the line recovery clinic, whatever. So you have all these options from free to super expensive. One of the things that we get a lot when people call us, and we're not outrageous for our consultations, but we don't do insurance and we charge $90 an hour, which isn't cheap by any means.
That's pretty good, actually.
It's reasonable though. It's very reasonable. And a lot of people don't know that, but the reason, especially younger crowds, but the reason why I'm saying this is when someone is willing to make a financial payment, when you have a substance use addiction, your money is going towards the substance. It is like all my money, all my effort, all my energy, all my time is going to pay for this drug, okay? Whatever that drug is. And when we're bringing in clientele at the place we're at in someone's recovery, again, we come in at a very specific point. We like to see the person willing to make that initial investment in themselves. And that tells me something like, I know Joe is capable of getting $90 to see me because he's spending $180 a week on whatever it is he's buying from his dealer. So I know Joe can come up with the $90 to see me. And I love meeting a person at that point when they're willing to make that investment in themselves, because you want to get sober. So many people want to get sober, but there's that initial little push. Like, are you going to invest in yourself? Now, some people don't have the financial means, and that's where you got all the free stuff, which can be great, all the treatment centers and all the facilities. But I think there's value, I guess, in what I'm trying to say, in saving up some of that money for a really good consultation or for a really good treatment. Someone in here said they spend $300 a month and they get access to all their doctors, all the text, all the telemedicine. Like, there is so much value in that $300 a month to be able to have that access to someone. So I guess what I'm saying is I think there's some value in paying for things out of pocket. And it's just, I don't know how else to put that.
Let me. I'm so happy. You got a great insight. Let me formalize it for you.
Yeah, that was a little. Thank you.
And I'm so happy you brought this up. Look, my own background. I come from academic medicine, and then on top of that, I always chose to work at county facilities because I like populations like that, right? And when I went into private practice and left the university, one of the most difficult things for me has been I don't know anything about money and business growth and all of that stuff, and so that's been a nightmare. And we really should be so much bigger, and we're really cooking, getting going now. But let me tell you what I've become comfortable with. Me and a few colleagues here and there would look at the way I have always done work, and they're like, "You've probably given away about $1 million worth of free care in the last 5 years. You're an idiot." But here's what I've also come to realize. What you said, when someone says they can't afford the office visit, I couldn't have put it better myself. You've spent a lifetime being absolutely the smartest person in procuring the drugs in any way you can. Now you can't do the whatever it is so you can have a lifetime to make 100 times more money. And I'm not being mean, and I'm not trying to get anyone's money, but you're telling me you don't have a vested interest in your recovery and treatment. In addition, you're sort of behaving like an addict because you're telling me I'm sort of a potential, or not me, but telling my organization, it's your duty to treat me, which is a very narcissistic approach to things. And so I couldn't, I've learned, I don't like to be in between money and patients and stuff like that anymore. And I have the choice to do that now because it's something I'm uncomfortable with. But I've had to be stopped to give care for free, and I still give it. And we do have people that we really take care of for pennies on the dollar. And you know what? They pointed out to me, like, Dr. B, your organization is starting to reach to the hundreds and thousands of people. Do you want to go broke and everything to shut down because you want to give one person free care? And so I agree with you 100%, and it's important for their recovery.
It's important for the recovery because that is part of the recovery. In our programs, we have like a financial section where we give people like basic financial literacy, which a lot of people don't know about, but like, here's the basics of index funds and here's the basics of savings. And we really try and help people rebuild their life. And that is one of the first, in my opinion, steps. Like, okay, I always tell people, and I'll kind of leave it this is one of a drug addiction is an investment. It is a serious investment that you're making. You're investing your brilliant brain, your time, your energy, all these incredible things, and you're doing a really good job with that drug addiction. But damn, if you just invested in yourself or in your recovery, just give me like a glimpse of it, and boom, then we can run with it. And I think you're going to go on to make way more than that $180, $190 that you
absolutely.
So, and the reason why we charge is because I'm like, I know you're worth it. You're worth that. That's why we're doing that for you. So, no, I agree. It's part of recovery. That is part of recovery. So
I'm glad you brought up this topic. Look, I know we were gonna cut this out, but I see Jeff on here from Grind. Shine Recovery, and there's Kat. Should we quickly answer 2 questions?
Sure, bring him in. That's
okay, we'll do this quick, and then we'll after. Oh, Kat left, so we'll do the. Here, let me bring him on. He's great. Okay.
Hey guys,
buddy,
how you doing?
What's up?
I've been meaning to actually call you. I got your number posted on my wall here because Austin told me you had a question, and I will do that. In fact, I'll do it right after this.
Okay, I appreciate that, Dr. B. Really, I just wanted to talk what you guys were just talking about. That is a great topic, and I do think you got to have somebody who is willing to, like you said, invest in themselves and actually wants change. And it's a slippery slope also because I feel a lot of doctors aren't getting the value. Like you said, you do financial training with people. That's great. You're getting value out of that. You know what I mean?
That's actually amazing.
I wish more doctors followed your guys' role, because a lot of doctors, they're not getting under, they're not scratching the surface, I feel. A lot of treatment, they just prescribe the medicine, and that's really the only value they're getting. Because it's a community drug addiction. A lot of times is almost a community issue. At least the way I grew up and the way I lived, the first part of my life, a lot of times it's second nature to people. They see it in their family. It's generational.
Oops, Dr. B, I think you got dropped.
Sorry, go ahead.
You're back.
So it takes what you guys are talking about of actually giving the people some value and teaching them, like you said, how to balance that, their money, how to save them things, because a lot of times people don't have that. You know what I mean? Now the downside to charging, I feel, is I could make hundreds of dollars a day when I was using, because I was willing to do illegal stuff, whatever, to make money.
You're right.
When I got clean, coming up with money was a lot harder, because I'm a felon, I'm legally blind. Getting a job that'll just hire me alone is a challenge. So that's why I feel it's a very slippery slope. But there is help out there for people if you don't have money or anything. There is help. And that's, one thing I try to always offer help to people is finding them help and support in their area, because the long-term thing with recovery, at least that I found myself, is it's the community I put myself in, I guess. You got to build a support network around you. And, I've had to cut people out of my life. So what I'm saying with all this is I feel more people in recovery should be integrated into treatment, to be like case managers, to help show people, help lead the way. Because I don't feel a lot of treatment centers, they have people who know about addiction, who studied addiction, but understanding how to have to build your life and maybe have to cut close family members out of your life to stay sober so you can live a life. There's a lot to that. So I feel there would be value if more people who are in long-term recovery were integrated into, helping with drug treatment. What's your guys' opinion on that?
Should I go?
Go ahead.
Yeah, so the first thing that you said about the payment and the difficulty, it's something I actually never thought of. Thank you for that insight. And I do work with people that I feel really need that. So thanks for that insight on my end. As far as what you said, I absolutely advocate that. On the other side of it, what I see in treatment centers down here in Southern California, like right now, I've known you for actually a couple of years, I think, at least.
Yeah.
And I actually, every time I see you, you are, because I've done this so long, and I think I'm pretty, I look at you, I'm like, wow, I can even tell from the tone of your voice, you've improved, you're getting better and stronger every day. And
thank you.
And I just almost touched me a second ago. It's impressive. Having said that, what I see down here, guys, is a guy goes through rehab in one of the programs down here, and 3 months later he's running groups because he took his thing, or 2 months later, and it just happens. So yes, people from in recovery, and in fact, a lot of people in our program are in recovery, I believe. But it should be a sober-minded approach to bring in that person on, and making sure they also get a little bit of training and professional maturity and sobriety, professional sobriety. Now you can use someone like that to truly give meaningful feedback and help with the road to recovery for the addict. So I do agree with it, but not so early on and in the way I've seen it down here. That's my
and I completely agree. I think you definitely want to. I think people should have, like you said, long-term sobriety, just because it's a disease, and it's something you have to stay on top of it. And that's I feel a lot of treatment don't prepare people for when they just start living life, of how to handle certain situations, and I appreciate you guys doing what you're doing, because a lot of people have a negative opinion on which I completely understand, but it's necessary to be treated like a disease. I know millions, I see millions of people who MAT treatment has saved their life. So I'm glad you guys are out here, letting people know and educating them about these things.
Doc Frank, let me tell you something about this guy. When I see him, it's, and I want to give you a little bit of my thought, because I do get, I see, when I see something like this, and I've known him for a while. I know about him. I actually follow closely. And you're always worried about them. You're like, okay, he's on a good trajectory. I hope it goes well. I hope it goes well. I can't reach out to him time. But you get a really deep sense, a visceral resonance of the struggles each one of these guys goes through. And this young man is one that I've peripherally known for quite some time. And it's kind of funny, different things, maybe I'm nuts, but different things come to my head at different times. When I see him, the thought that kind of goes through my head is, wow, not only is he really kicking ass, I don't think anybody understands the difficulties he's gone through. I could be wrong, but I'd like to think I'm a clinical magician. And because I haven't had him, we haven't had that close of a contact, but I know of him. But the difficulties he's gone through, but he walks like a soldier, keeps his head down, is not demanding a pat on the back, is engaging his world around him as best as he can. He's dealing with all of his trauma in his entire life and keeping his head down. And you know what? That's what should be freaking celebrated, right? That's what we should have a 4th of July for, right? That's what our national, constitutional, societal values should be. And in the big picture, people don't know what I'm trying to do, but in the big picture, I'm trying to have a value shift in our society. So we have empathy, compassion for our brothers or sisters or children, our neighbors. Because when I look at him, that's what I see. And I'm like, damn, he's kicking ass. And damn, it's almost like the soldier without any medals, or glory, or whatever that saying is. He's amazing. So I celebrate you, man.
Hey, I appreciate you, Dr. B. And I appreciate you guys, carrying the message you're doing. So.
I can say this. I love the name, Grind to Shine Recovery. I think that's awesome.
Yeah. Well, like I said, I try to reach out and let people know, I offer to help people if they're just starting in recovery, help find support for them. Because I know finding that help, there's a lot of stuff out there to help people. But when you're just trying to get clean, it's not that easy, because you're in such a different lifestyle.
and how people reach out for help, I think, is going to change dramatically, especially with a younger population. And I think a lot of it's going to be through technology like this. With that said, and it's easier access, it's free access, and it's easier access, and which is really important. Even though I talk about charging, I wanted to say as well too. Oh, I have to run, but it was excellent talking to you. Grind to Shine. What's your first name?
Jeff.
Jeff, great talking to you, Jeff.
Hey, great talking to you guys too.
Dr. B, you as well, and everyone else on the team. I got people filing into my office now.
Go ahead. I'm going to answer Kat's question, but let's do this again. But Kat's been waiting a long time. I got to run, but I got to answer her question because she's been there. Go ahead. This was awesome. I really enjoyed it. Let's touch base afterwards. And
we'll try and do it. We'll make a thing of this. We'll try and cover some stuff. Yeah, very neat.
Reach out to Austin and Nicole. They're rock star good people. And bye, Jeff.
All right, you guys have a good one. Have a blessed day.
Jeff, that's all right. That's okay. Jeff, if you're still listening, I want to say he should check out some of the local addiction recovery programs in his area. Like I had to go through a state certified one because you can get them online and stuff. But for addiction recovery coaching, that's the start. When you're at that level, wherever it is, that's that start of that like basic education, I think, that is really good when it comes to, you were kind of talking about like some training before you just jump in there and stuff. Anyways, check that out if that's something you're interested in. You can find it in your state, in your area. And they're starting to use these recovery coaches, like to his point, in hospital settings and other settings to help people get set up in case the attending physician, this just isn't their thing. They don't know, how do I get this person to a program? How do I do this? How do I do that? You're seeing some really neat things in those programs. So I gotta go, guys.
All right. I'm gonna talk to Kat. Thank you. I'll talk to you soon.
Bye, guys. Yep.
Hi, Kat. I hope I can answer your question.
Dr. B. Oh, I'm so glad that I can actually talk to you. It was meant to be. I chatted with Nicole a little a few nights ago. I've been watching your videos, and I can't agree with you enough that even when you're in recovery medication, like I'm on Subutex, the self-management is not working. And some of your videos that I've been watching about, like if you want to self-manage, you fail. That has been proven to me that I need more help, and I'm not complaining or like want to put anyone in a bad place, but a lot of doctors just give you the medication and tell you just take it, and don't monitor you. And that's where I am, which self-management has been a failure for me, and that's why I wanted to reach out to you and to talk to you. And I think the question I have is, I don't know if it's a question really, like a lot of us need help because we are just on our own with these medications that they can be addictive. And for me, it's like I'm totally being honest, I've been taking more than what I have been prescribed, and at the end of the month it comes to, I have to go through shit for a week because I can't get my medication. So I mean, is anything that you can talk to me about? I mean, I would definitely reach out to Nicole and see if I can work with you, because I need a doctor like you. I'm at the end of my rope, pretty much self-managing, very bad, taking more than what I'm supposed to take.
What state are you in?
Well, I've been on buprenorphine for.
No. What state do you live in?
Oh, California. I'm in. Actually, you said Sunnyvale. I grew up in Sunnyvale too. I am in San Jose, Los Gatos.
Oh yeah, my sister lives in Palo Alto. Reach out. I will tell you this: managing. So of the, I can only give you some general things here.
Right.
Of the hundreds and hundreds of patients I've had on buprenorphine products, the ones that clinically that I've become aware of and had to manage overtaking the subs is 1, 2, 3, 4. 2 of them had to get discharged from the clinic, and 2 of them are great people. And one of them, I think, is on here right now, and the other one's wonderful. And it takes a half a second. What I do, I'm sorry, there's another guy too, but he was misusing a lot of things. And what I do is in my practice, well, first we figure out the roots of it and whatever it is. There's a million different things. And once that happens, if I need to, I will go to weekly scripts and follow-ups. And in a very short period of time, a lot of it is about patient education. A lot of it is about figuring out why they're doing that act. What is the root of the addiction? And these are pretty easy at that point. Very few people, I'll leave you with one last thing. I always tell people, a monkey could write you a prescription. I'm not a monkey. I'm a doctor.
Yeah.
And so, once you write the prescription, you have to take accountability, responsibility for the knowledge, education, and management of that with the patient. So reach out. This is a very easy problem to solve.
Thank you so much. I mean, I'm glad to hear that. And you're the best. I mean, I don't know of anyone else. I have researched for so many years. You absolutely understand, each one of us. And like when I was watching your videos one after another, like a few nights ago, and I was like, wow, I really need to reach out because this is a problem I have and I need to figure it out. It's exhausting. It's just exhausting, but it's definitely, I will reach out and I will work with you, and I want to just get on the, on the track and see where it goes. Well, I really appreciate you take all the time to talk to all of us. This is just unbelievable. Thank you so much. Thank you.
Thank you. I appreciate you guys. And yeah, yours is easy. And thank you for coming on, Kat. I'll see you soon.
See you.
Bye-bye.
Thank you.
Bye-bye.
Bye.
Hey, everybody, and on TikTok, and I suck at turning this thing off, and on YouTube. Thank you so much. Nicole, I am gonna sign out. And if you remember, I had hey guys, this will be on the YouTube. God, will I be able to see their questions? I like to go back and try and answer some. I always feel bad, Nicole, if I can't answer it. Okay. Nicole, I don't know how to turn off the TikTok. Remember, I had a hard time last time. Oh, I see comments. Okay. Hey, guys, can somebody tell me how to get off this? Bye. Hey, Scotland, bye. I'm glad you came on. Nicole, how do I get off my TikTok? Hi, Mama. Thanks, guys. Thank you. Thank you. Thank you. Thank you. Thank you, guys. I got to run and see some patients. Hi, Happy. Hi. I just don't know how to get out of here. Guess I'll take you guys all with me all day. I'm in Orange County, California. Guys, I got to go. How do I get out of here? And I feel bad not reading your text. Okay, I'm going to try and get out, okay? I'm going to ignore your text. Close my app. Okay. Okay, guys, bye. I'm sorry if I didn't get everyone's questions. I'm trying. Close my app. Nicole, how do I get out of here? They say close my app.
Okay, on TikTok, go to the bottom right-hand corner of the screen, and there'll be a little round button. You press it.
Oh, I see it. Okay, someone's like, keep them hostage here. Okay.
And then that'll press end stream, and then on YouTube, you'll go up to the top right-hand corner, and it'll say end broadcast. Make sure you fully end it, though, because it'll stay recording if you don't.
Okay. All right.
Okay?
All right.
You did great. Awesome. I loved it.
Yeah, but I wish you were here because I was trying to answer people's questions and I can't, and especially the TikTok folks because I can't see the